Welcome to our Bronze Corporate Member Symposium. And as every time we do this, I'm always humbled and honored by the fact that we have so many folks that are willing to come in late in the evening after a long day hearing about MRI. Your brain is probably just about full, but yet you're willing to come in and spend some time with us, have some refreshments, and listen to a refreshing point of view. So thank you. Thank you for giving us the time. Dr. Tanenbaum will speak to you shortly, but before Dr. Tanenbaum brings his presentation to you, I want to take a few minutes of your time to tell you a little bit about Fujifilm. And I'm going to do it in a little bit strange way, perhaps, but I have to say something up front. I'm very conflicted. Totally conflicted. So I'm a Fujifilm employee and have been for some time. So just understand that going in, but you can trust. So the things that I'm going to say here tonight are things that you can believe. Dr. Tanenbaum, likewise. Everything we're going to talk about tonight, and this is an important point about Fujifilm MRI in particular. Everything we're going to talk about tonight is not an extra cost option. It's all part of the standard package on our high field MRI system. A very important point about the way Fujifilm approaches its customers and what we think about MRI, what our vision for MRI is. So keep that in mind. Does anybody recognize this? Okay, Star Trek. So I grew up in the 1960s and 70s. And Star Trek was very much part of my formative years and affected my attitudes. And this one episode, does anybody remember what this episode's name was? Okay. It was called Let That Be Your Last Battlefield. And the point about this was, it was about prejudice. And prejudice is something which is one of the most damaging things in the human experience. I think we're wired a certain way to be prejudiced because we need to be pattern recognizers. But sometimes we recognize patterns that aren't even there. We try to put things in a neat little box because of the things that we prejudged about, that we think about it. In this particular episode, these two gentlemen were at odds with each other for millennia because one has a plaque on one side of his face and the other one has it on the other side of his face. And they were at odds about that. So when I say Fujifilm to you, what do you think of? What's the first thing that comes to your mind when I say Fujifilm?
Film.
Oh, imagine that. Help down here from Dr. Tanenbaum. Yeah, you're thinking about film. You're thinking about cameras. You're thinking about photographic film. You might even be thinking about X-ray film, and that's fine. We make boss film. We make great photography equipment. We make great X-ray film. We make great photographic film. But I want to tell you, there's more to Fujifilm than that. Fujifilm has a wide array of medical imaging alternatives. We make ultrasound. We have a full line of highly sensitive detector technology installed all over the world using thin film transistors, hence Fujifilm. We have RF room equipment of all different shapes and sizes and capacities. C-arms. Fujifilm has a full line of C-arms. Mammography equipment, a very high performance mammography system. We have CT. We have a very dominant PACS solutions installed all over the world. And to the point of what we're here about tonight, MRI. We have a 0.4 Tesla vertical field permanent magnet technology-based system installed all over the world. We have a 1.2 Tesla superconducting high field open MRI system installed all over the world as well. And we have a 1.5 Tesla system, Echelon Synergy. These three systems are installed in the United States, in Asia, in Africa, in South America, Europe, everywhere around the world you'll find our equipment. As a matter of fact, we're approaching 9,000 installations worldwide of MRI. So the next time you think about Fujifilm, think about MRI. Well, why Fujifilm MRI? I want to break your prejudice tonight in some of the introductory comments I'm going to make. Dr. Tanenbaum is going to take it to the next level and talk to you about the clinical application of these things. Very interesting information he's going to share with you. I just want to give you a taste of a couple of things, which will help you answer the question, why Fujifilm? And some of the discussion here, a little bit of it's going to be technical, right? You're very technical people typically, so that'll be fine. But there's also a little bit about the relationship we have with our customers. We deliver a relationship like none other in terms of the people that are selling high field MRI or high-end MRI equipment today. So why Fujifilm? We think about her. We think about the person that has to operate the equipment day in and day out. You know what? We're all propeller heads. We're all into the technology, aren't we? We eat, sleep, and drink MRI. That's why you're in Honolulu. It's not a horrible place to be, right? But primarily you're in Honolulu because you're an MRI person and you think it's the coolest thing. Guess what? Not everybody that operates an MRI system is that turned on by MR. It's their job. It's their job, right? Also, think about the other end of the whole chain, the patient. The patient's not there because they're turned on by MR. When they go home, what are they going to say? I had a CT scan, right? They're not even going to know they had an MRI scan, right? That's the patient. But they need to be treated in a certain way. And the technology that's delivering the diagnosis around them needs to be conformed to them and not the other way around. We're worried about the things she's worried about and what the patient is worried about. All of these things. Now, I'm not going to talk about each one of these things and how we bring a superior solution for each one of these things, but I do want to mention a couple. What's she worried about and she worried about? That technologist, that radiographer, and that patient. What are the things on their mind? Scan time, signal to noise ratio, resolution, motion, volume. What do I say by volume? I don't mean how loud it is. I mean, how many patients can I get done in a day? The technologist is worried about that kind of thing. Anxiety on the technologist's part, of course. But what about the patient? The patient's worried about the scan. They're sick. They're a little bit scared. How about rescans? Of all the things you want to avoid, is you want to avoid rescanning the patient. That just makes anxiety go through the ceiling, and it kills your patient volume as well. And what about support? Once you've installed the system, how is that company taking care of you? Big question. And then finally, she might have on her mind helium, and maybe you do too. The thing that we've dealt with in MRI, since MRI, is some unfortunate relationships. And these are not, I'm not an MRI physicist, and believe me, I'm in no position to lecture on these things. But what I'm seeing here are the relationships that we deal with that are tough. They're tough in the sense that I have an adversarial kind of relationship, do I not? With these three things: sequence time, spatial resolution, signal to noise ratio. These things tend to fight with one another, and then you have these horrible equations, right? Signal to noise ratio is proportional to field strength and all of those things. And the problem is, when I'm designing the scan that I want to do that's going to deliver the diagnosis that I need, is that I'm fighting with all of these things all at the same time. It's like I can't get shorter scan time and get good image quality. I can't get high spatial resolution and get short scan time. That's always been the problem, hasn't it? That's the thing we struggled with since the 1980s. Well, enter deep learning reconstruction. I don't think anything's changed MRI like AI has changed MRI recently. I think this was recently called, AI was recently termed like the new electricity, which is a great term. And you might even hear Dr. Tanenbaum mention that in his talk. But it's changing the way we live. It's even changing the way we scan. Think about that, how profoundly different the T2 scan is today from what it was 20 years ago, even with parallel imaging and all of those things. So now I can undersample K-space in whatever. I can use parallel imaging. I can use some kind of reduction in my number of acquisitions, or I can maybe go the other way and increase spatial resolution. I can do all those things that used to make the images kind of bad or extend the scan time. I can do all those things, but now through the magic of deep learning reconstruction, I can get a great image, even though I'm doing all those things that used to cause me so much trouble. And that is a wonderful thing. And Fujifilm, right now in our high field products, provides two forms of deep learning reconstruction: deep learning rise and deep learning clear. And we're not done yet. Our Riley program, R-E-I-L-I, you don't have to memorize that. There won't be a quiz later, but that term represents Fujifilm's initiative around AI just now, and is bearing fruit in terms of the reconstruction that people are able to take advantage of on our high field systems. We have DLR Rise, we have DLR Clear, and we've just recently started to introduce something called DLR Symmetry. Our DLR Rise application takes that signal to noise ratio of that scan and raises it up and gives you a beautiful scan. And if you look closely, unlike the old days, we're not losing detail, we're enhancing detail at the same time, which is just flipping amazing. And our DLR Clear application allows me to do this isotropic fast spin echo acquisition, where I would usually see lots of truncation artifacts. I'm able to clean that up. It's even in the MPRs then, I get a great result. We're using our DLR Clear standard equipment on our Synergy 1.5T. Now, we're just now working on, as a matter of fact, it's FDA pending, a new version of our deep learning reconstruction, DLR Symmetry. And DLR Symmetry takes advantage of some stuff, again, that we used to do with K-space. We would undersample K-space in terms of half scan. You remember partial necks and those kinds of things. Well, the problem is when you did the partial nexus, how did you make up for it, right? You did a complex conjugate calculation to figure out what the missing K-space lines were, right? Well, what if you use deep learning instead? Well, what happens is now is instead of doing conjugate symmetry, I use K-space, I get fantastic image quality. Look at that. I went from a full scan to at 16 seconds down to 10 seconds. But with the artifacts you would expect to see. But then I apply my DLR symmetry and poof, the artifacts go away. So I have an excellent scan with a, right off the bat, 30% reduction in scan time. Amazing, amazing. How about in prostate? I'm able to do things like with the TE. Here I go from a 92 TE down to a 72 millisecond TE with much better image quality in the prostate. So now those unfortunate relationships, boom, gone away, because of deep learning reconstruction, standard equipment. But there's more. What else would this technologist and maybe even that child be concerned about? Because remember, that's what it's all about. That's what we do. They're worried about, again, anxiety and so on, but also the rescan concern. Nobody wants to get another scan, least of all a child that couldn't hold still. Problem is, people move. And when you're going to get a scan, what's the thing that they tell you? And they're very close about. Don't what? Don't move. Don't move, because you'll mess up the scan. They'll have to scan you again. That's just not cool. We've got technology now that we can have the patient not have to be so worried, a sick patient, have to be so worried about holding still. Let's deploy that technology. We tell the patient, don't shake, don't sneeze. Don't do all the things that humans do. Don't move. Wow, what are we going to do about it? We have our motion clear, motion correction suite. Again, all standard on the equipment. We have to manage breath holding problems. We have our navigated still shot feature. For our radial scan applications, like in the shoulder where the respiratory motion and other things kind of make radial scans not be so great, we've got our IRCM feature that we deploy to clean that radial scan up. Patients distressed, they were fine, and then all of a sudden I got to abort the scan. In the old days, you would lose the images, not with Series Save. With Series Save, you get to be able to complete that. And then finally, how do you deal with sudden motion? You had a patient that was still the whole time. They were great. They were great. Then they fell asleep. And right when they fell asleep, they jerked. You know what happens when somebody jerks like that? That is a motion artifact and might compromise the scan. Synergy Vision and Still Shot, standard equipment on our 1.5T takes care of that. If you look closely what's going on here, this gentleman's being scanned. while he's monitored by a camera mounted in the front of the magnet and at the back of the magnet. So 2 cameras monitoring you throughout the scan. And if you move, we'll detect that motion right there. We'll find those lines of case space that were affected by that motion, and we'll use some intelligent processing to reprocess those lines of case space and get a great image. So what would have been an artifact-filled motion image now comes out just great. No rescan necessary. Again, all standard equipment. And by the way, if the patient has some trouble with their breathing or they're moving, there's an automatic alert that happens. It tells the operator that the patient's in distress. Another great feature of our products, part of the standard equipment. So we've taken care of a lot of things those folks are worried about. What else? The post-sale relationship. Now you might think this is boring, okay? But if you have anything to do with managing MRI equipment in terms of being responsible financially, you'll know that one of the big worries about it is I install this stuff and then I have a radiographer technologist change jobs and they're no longer available. I got to bring new people in. How do I get them trained? Well, one of the things that Fujifilm does, which is absolutely different from everybody else, is we'll come in and retrain your folks if they need additional training, or if you have new staff, we'll take care of them. We'll take care of them and provide that training, just as part of the relationship that we enjoy with our customers. All right, so you see Fujifilm, what are you thinking? What are you thinking? Sure, great film, right? Great film, but also some wonderful MRI solutions. You thought I forgot about helium. I didn't. But if you want to talk to us about helium, come to the booth E25 tomorrow. We'll be glad to talk to you about helium and the lack thereof. All right. Just now, it's my honor and privilege to be able to introduce a man who needs no introduction, Dr. Tanenbaum. Larry Tanenbaum's a thought leader in advanced imaging for decades now, and has perspective on CT and MRI. And one of the really cool things about him is that he is very sensitive to the business of MRI as well, and the patient experience. And he's also interested in where AI comes in from the time the patient walks in the door until the diagnosis is delivered, and even before the patient comes in from a scheduling standpoint. So I ask you that for the next few minutes here that you give your full attention to Dr. Tanenbaum.
All right, so great. That was a wonderful introduction. I would say wonderful, hopefully for you. It's very intimidating for me to follow Shawn. He's a fairly dynamic presenter. I don't have the range or the voice that can reach the back of the room, but fortunately the microphone will help me out. And we're going to talk about some of the things you already heard about and cast it all in light of where AI is impacting on the entire process. We all know what AI is. It's essentially a tool that lets computers do things that are ordinarily associated with human intelligence. We know that it's all around us in day-to-day life. You can see in the business world, there's been a significant adoption of AI. In 2017, it was only 1 in 5 companies had AI. By 2022, 50% of the companies were involved in AI. You can see that even in 2022, 70% of companies found a revenue source in using AI. The global market size for AI is roughly $40 billion in 2025. And it's expected to go to $280 billion by 2030. And it's the AI and healthcare software market that accounts for most of this market share. And you can see from this chart, we're just getting to the point where there's starting to be a fairly significant rise to that curve. Now, right now, about 94% of healthcare companies are using AI and machine learning. 25% of hospitals are already using AI-driven predictive analytics, and 53% of the European Union healthcare organizations are planning to use medical robotics. And 42% of the EU organizations are using AI for disease diagnosis, with further adoption coming soon. With respect to the attitudes of clinicians and radiologists in the field, you can see that across the globe, North America, South America, Middle East and Africa, European Union, a significant number, more than significant number, the majority of users nearly are predicting a significant role for AI in their clinical decision-making, which is a pretty remarkable step forward from when I first gave my keynote at the RSNA in 2017, where this was all quite fascinating. Right now, we know where AI is. It's better than humans at image recognition. It's better than humans at speech recognition. And this is really what's behind things like large language models, being able to pass some of our board exams in day-to-day radiology. So it's pretty remarkable stuff. The hottest topic right now are these foundational models, and this should substantially accelerate creation of these new capabilities across the board. You can see you can take one model, train it on a certain varied data set, and then it just gets capabilities that you would ordinarily have not been able to imagine. You can see, if you look across the healthcare enterprise, everything from utilization management, no-show analysis, image support, synoptic reporting, results communication, all across the board. These agentic AIs, these large language models, large language and vision models are impacting on some of these techniques we have today. We're going to spend most of our time looking at the imaging space directly, but just coming out of a 9-year relationship with the largest outpatient imaging company in the US, these tools are all being either used or being actively developed and building into the ecosystem that we all work in radiology, and it is without question like electricity. I always like to think of the days when we shifted from gas lamps on the walls to light bulbs on the walls, and people walked around saying, "Wow, electricity! Wow, electricity!" Now they just say, it's just delightful, right? So it's the same type of thing. AI, everything's AI. But right now, we're just transitioning into different capabilities in day-to-day business that are facilitated by this new capability, artificial intelligence. All right, so we're here to talk about clinical work. We're also here to talk about how these AI capabilities can impact on the patient experience. And if you look at this survey that was actually solicited by the folks at Philips Healthcare, they asked patients from the US and from Europe what they thought about the experience in radiology. And as opposed to the fairly good ratings they gave their doctor's office, they didn't think much of us in the imaging space. The concept that patient satisfaction is important is reinforced by this particular paper that basically said if your patients are happier, they'll come back. If your patients are happier, you'll get better imaging volume. So patient welfare, patient experience is critically important. Now, from that same survey, if you ask the patients how they felt about MR, they said some of them didn't mind it too much, and some found it long, tedious, and nerve-wracking. Others found it scary and painful. If you look at some of this data from a variety of sources, patients feel real sense of anxiety in the machine. 30% of patients get real anxiety reactions. It's not really a pleasant situation. And if you don't feel comfortable, you end up moving, and that essentially just gets you a longer exam, and again, makes the whole thing a lot worse. Now, the folks at Fujifilm have been pioneers in this particular space, particularly in terms of putting a high field system, making a high field open system available for this patient population. When I was at RadNet, we had roughly 40 plus of these high field open systems throughout our network, and at a very, very high level of clinician satisfaction and a very, very high level of radiologist satisfaction. Now, these systems you can think of as being developed for patients that have unique challenges like size and claustrophobia, but in many of our sites at RadNet, we use them for all comers, and it's nice to have this particular platform. As a matter of fact, this is a shot that we turned over the first version of this. I look much younger though, right? And the rest of these guys are just bandits that are by the side of the road. Some of them are in the room. We'll do a mix and match later. But again, turning over the first and the second generation of these machines, the Velocity system, which has really been fueled by some of this AI you'd like to talk about. But getting back to the patient experience, we actually asked patients to rate the experience in the magnet on this open system. And when you look at category 3, category 4, either met or exceeded expectations for comfort. They rated the noise level satisfactory at 70%, the overall comfort 85%, and the actual length of the exam, even though it was marginally longer than a 1.5T scanner, still got very, very high ratings. Again, speaking to the comfort of the system and the importance to patients. Now, another thing that patients say, again, from that same patient survey, is I want to get it done right. You heard the theme first time right. I want you to get it done. Don't call me back because you missed something. Don't call me back because the images weren't right. And that's really quite important. Excuse me. Now, you heard from Shawn that, our old biases against Fujifilm or, the family that built some of these scanners, Hitachi beforehand, was they made good, solid, everyday bread and butter machines. But you're going to see from his presentation, you saw, and you'll see in mine, that this is a company that is heavily invested in technology and moving very, very fast. Okay, like the old Oldsmobile 442 used to move in the old days. There's no one in this room that even knows what that is. Anybody know what that 442? You're all way too young, but it was the hot rod that Oldsmobile made, and all my friends wanted one. Of course, I never got one. I drove a Rambler. All right, so again, we heard about, how do we augment our ability to get things right the first time for our patients, and how do we use AI to do that? And we'll talk about this over the next, say, 20 or 30 minutes. And one of the ways that AI can help us is by helping us avoid those repeated scans. And the way they can do this for us is to do things like use deep learning driven autonomous scanning. I think autonomous scanning is clearly a trend. It's clearly where the industry has to go over the next few years, and we're seeing the first stages of this now. And this is somewhat facilitated by these very simplified, error-proof user interfaces. Now here, this is the place where we dream of what tweak we can do for MR scanners, but in the field, you don't want to have tweaks. You want consistency, you want standardization, and as our technologists crew is younger with less experience, it's even more important to take some of the variability out of their hands. And one of the coolest things I've seen out there is this one-touch auto exam. You simply just say hello to the patient, loads the protocol, and you go through the demonstration of the exam. This is going to be time-lapse. You can actually see the time of the examination here. There is music on this, so, I didn't ask for sound, so maybe Mr. Etheridge can sing along here. Oh, yeah, we got sound. I think the way that next coil goes on is really ingenious. It really does give you really close proximity to the patient. See how quickly it sets up, even though it wraps completely around. As soon as he closes that door, the scan starts. And that gives you just a little bit of time benefit. Now, when your scan time starts to run for 10 minutes, those 30 seconds here, 30 seconds there really make a big difference. We are in time lapse now, so let's keep that in mind. We're already at 6 minutes. And by the way, even processing the MRI on the fly, all done automatically, again, to create a consistent product, technologist to technologist. So it's pretty remarkable. Like you can get an entire exam, acquire the exam, vet the exam, process the exam, and say goodbye to the patient all in less than 7 minutes. And this is entirely realistic. Now, again, part of the MR experience is discomfort that leads to motion, right? Part of the MR experience is trying to get it right the first time so they don't come back. And motion artifacts sometimes lead radiologists to ask for a return. You can see this is just not an ideal image here. Now, motion is a very significant issue across the country, across the vendors, mostly in the inpatient environment, and it leads to a lot of lost revenue that could be gotten because you had to repeat scans. What does it say here? Roughly 30% of inpatient exams needed to have sequences repeated. Patients have to come back. And it costs those facilities a theoretical $115,000 per year. So motion and repeats are not irrelevant in terms of overall costs. Shawn showed you this example. They have front and back cameras here that are watching the patient, and they will actually trigger you if there is some motion. You'll notice this patient eventually gets tired or gets anxious and starts to move. We start to see, the change here. We start to get alerts on the scanner. Hey, you maybe need to pause the scan or talk to the patient. This is critically important in terms of getting these things right the first time. Oh, look at that. Okay, so when you see this kind of motion, it tends to lead to suboptimal image quality if you have nothing you can add to that. Combined with the camera, the system has the ability to identify the lines in K-space that were acquired during this patient motion. It can actually remove those, and rather than filling them with zeros, use deep learning, use artificial intelligence to better approximate the information that should be in that space. And instead of getting an image that looks like this, they get an image that looks like this, which compares very, very well to this image that was acquired in the same volunteer without motion. Now, these days, we're seeing a significant increase in volume of brain MR examinations in the outpatient setting in particular, because of the opportunities we have in imaging patients with Alzheimer's disease. This is a paper that Dr. Bash who's in the room here with us, and I wrote an applied radiology looking at the unique requirements and the unique opportunities that are involved in imaging these patients. About 7 million patients, suffer from Alzheimer's disease. It affects 1 in 9 people over the age of 65. The prevalence doubles every 5 years after the age of 60. 1 in 3 of our seniors will die of dementia, and the number of new cases of dementia are expected to double with our aging population by 2050. There is a historic role for MRI, which is to exclude treatable causes of cognitive impairment. Does the patient have hydrocephalus? Is there a big meningioma? We also can detect and classify volume loss in the brain, which may give us a hint as to what type of dementia via quantitative assessment, right? And these are the typical quantitative assessment tools. We take brain volumes, we compare them to an age and sex max population, and the patterns of involvement in this case will give us a hint as to the differential diagnosis of dementia in these patients. And particularly important for these quantitative tools, and this is very difficult for human eyes to do, we can actually compare disease and volumes and white matter lesions and the like between visits using quantitative tools. And it's really exciting in the US because there is increasingly consistent reimbursement for this add-on brain analysis in the US, through a couple of CPT-3 codes. And that is leading to a greater importance of this tool and greater visualization. Now, the biggest excitement in this space is there are now therapies. There are anti-amyloid targeting immunotherapies that can loosen amyloid and facilitate clearance from the brain. The problem with amyloid, though, is it's inflammatory. Okay, if you loosen it, it triggers inflammation. This inflammation starts out in the vessel wall where a lot of the amyloid lives. And if you inflame the vessel wall, you get edema leaking on the surface of the brain as well as in the brain. You get hemorrhage on the surface of the brain as well as in the brain. It's referred to as RAE, 2 different types of edema, and RAH, 2 different types of hemorrhage, either microhemorrhages or superficial siderosis. Here's a nice example of that. Here's a patient with little arrows supplied by my friend Rachel Gordon. Here you can see some RAE, edema in the surface of the brain, and here you actually see sulcal effusions of edema on the surface of the brain. Here you can see evidence of siderosis, as well as microhemorrhages, all classic appearances of ARIA, amyloid-related imaging abnormalities. Again, notice the hyperintense sulci on this FLAIR scan, as well as the hypointense brain surface here with siderosis on this gradient echo scan. Now, this is a very important market issue because not only is MRI required for screening patients for risk of hemorrhage before you put them on a drug that may cause hemorrhage, multiple safety monitoring exams are required over the course of therapy. Depending on which drug they go on, they may need 3 additional scans over the first 6 months or 4 additional scans over the first 6 months. If you're at higher risk, say genetic predisposition for ARIA, you will get even more exams. If you have any complications of ARIA that require you to pause therapy until they resolve, you get even more scans. So it's not at all unexpected that patients on these drugs will see 6, 7, 8, maybe even 10 exams per patient per year. So good market opportunity, but also presenting us in radiology with a patient population that may be cognitively impaired, that may be very anxious, and may have trouble going through these exams. So again, even for this patient population, it's important to get things right. You can see some data that Dr. Bash gave me from our old institution. You can see that back in 2024, they were seeing a 20% increase in volume, and that continues even today. A 20% increase in volume over time. And that reflects largely screening exams, but now more and more patients on therapy. And that quantitative tool I showed you is also growing, again, in importance. And again, largely fueled by reimbursement and the value. Now, these amyloid-related imaging abnormalities have this incidence with higher risk with ApoE4 carriers as the primary genetic determinant of increased risk of Alzheimer's disease, as well as ARIA. But the majority of these events are mild and self-limited, except that there have been some serious events. And there's a lot of concern in the neurology population about these patients. So it's really important that we do our job, we give the appropriate information. Now, this is a technical MR talk, right? So what are the things we do on these patients when they come in? We do a 3D T1 weighted spoiled gradient echo acquisition. They're kind of prone to motion. You can use the still shot technology, which allows you to correct motion. Watch the camera, You can actually, even for this sequence, use a navigator. Notice when the lines are corrupted and replace them, and can get a nice image we ordinarily would have suffered. And remember, if you're going to do quantitative imaging, you need this series to work. Again, we do a flare in all of these patients. We don't want the images to look like this. We'd like them to look like this. We do a gradient echo on these patients. And again, these are long scans. In 2025, most of the longest scans we do in brain imaging are the old standard 2D gradient recalled images. And it's nice to be able to get an image that has some motion here. Not so bad, except if you try to count microhemorrhages. Okay, and in this case, we can correct that and get a gorgeous looking image. Now, these cameras are actually front and back and can be used not just for brain imaging, but for imaging across the entire body. Some examples of that, this is what the patient maybe didn't hold their breath to the full acquisition. We can correct that. Again, another one with some artifacts, easy to correct. Another one again, not so much here, just a little bit of breathing artifact. Again, and again, a substantial increase in the image quality. You might call this patient back. We don't have to, but you can go ahead and get corrected data through the use of AI. So the same technology, which allows you to go in and sort of clean up an image, IQ retouch, can be used when a patient bails in the middle of the exam. Now imagine you've got a patient who's got cognitive impairment. You're not talking them through the rest of the exam. Once they say, get me out of there, you're going to take them out. So if you have those lost views, you have to stop, you've lost the exam. And that really is quite painful. Even if you go back in, you now have a stressed, tired patient. Wouldn't it be nice to be able to say, okay, I'm going to take what I've got here and be able to create an adequate image by using AI to fill in those missing lines in K-space. And this technique they call series save, but it falls under the IQ retouch. And you can see how this plays out. This is a patient, this is a volunteer. We did the full scan to 223, but then we actually had the patient just quit at 142. So the patient was off the scanner before the scanner counted down to 0. And we're still able to make an image. Now it shows a little image compromise, but the fact that we got an image that we can use instead of having to repeat the scan or repeat, have the patient return when their anxiety levels were lower is absolutely priceless. And again, the brain volume is up 20% US wide, probably almost as much in other areas where these drugs are available. This is not an uncommon problem. It's common. Now, just to give you another sense of how this works, this is a volunteer, we asked to move. And we have two different techniques that we can deal with a patient who can't cooperate. We can use still shot to clean this image up, and it looks pretty good. We also, if a patient bails on the complete series, after only about 3/4 of it, we can actually still get a gorgeous looking image, which really looks almost as good as anything else we see here. Now, again, there are other problems we get in day-to-day imaging that can contribute to, gee, I wish we had a better scan. Maybe we should bring the patient back. And that falls into the range of parallel imaging failure issues. And sometimes you just get aliasing just when you don't want it, and it really is a problem. And either you have to live without the scan or you bring the patient back. Wouldn't it be nice if you could actually adjust the aliasing factors, the parallel imaging factors, so that you can correct that retrospectively? Or ideally have the system recognize it and correct it prospectively? It would be pretty remarkable stuff. So essentially that same IQ retouch family can actually redo the scan, but change the parameter retrospectively and actually correct that image without having to rescan the page. So again, take this data, retrospectively correct some of the parallel imaging factors and get this image out as a result. I think it's pretty impressive stuff. Again, we've got some aliasing here. Unfortunate. Go back to the same data, you don't have to repeat the scan, go ahead and change some of the parameters retrospectively and get images that look like this. It's pretty repressive stuff. So the ability to correct for motion, the ability to correct for aliasing, the ability to correct for a patient who could no longer tolerate the examination, and we'll see much more of this now that all of these patients with cognitive impairment get on the scanner, all very, very powerful stuff. So again, all different types of disturbances that would lead to your inability to deliver first time right. Sudden motion, we can deal with that with still shot. Breath hold failures, you've already seen examples of that. If the patient's likely to move, we're more likely to do a radial scan. And not every vendor can actually do a modified radial trajectory propeller, radar type scan with deep learning. But as you can see from this slide here, this is in the Fujifilm tool chest right now. And that would probably make, put them in the, only about 50% of the vendors can do that right now. And again, I think our unique capability, taking a scan that is aborted because the patient couldn't stay in there any longer and getting an image that's diagnostic is a very big deal. All right, last wave of the presentation, going back to the patient. If you could change something, what would you do? It's the length of the exam. Okay, they just want to get out of there shorter. As a matter of fact, it's not just preference. This is a New York Mets pitcher that said he was on the injured list longer than expected, because the position he was in a New York City orthopedic imaging hospital was so uncomfortable and so provocative to his, I guess, his elbow tendon, that he felt that his rehab was extended longer because he was in there so long. So it's not just, transient comfort. When you put athletes in these positions, they can actually extend their injury. So regardless, shorter exams are better, right? So this is another paper that Dr. Bash and I wrote on deep learning image reconstruction. You'll find a good sort of basic approach to where we were at that point in time, I think back in 2021, in terms of covering these issues. But I think at this point, we all know that AI-based image reconstruction is a very powerful denoiser, almost equivalent to 15 times the acquisitions or nets. It preserves or sometimes even increases sharpness and spatial resolution. And it does all of this while boosting the contrast resolution, which again is what makes MR so special. The basic version of this, I'm using different terms than Shawn did, maybe because he's a marketer and I'm just a pure simple country doc, or two, because I just didn't understand the terminology to start with. We just use this on the street. We'll start off with IP rapid, which is essentially an iterative reconstruction, right? We do know what happens when we do parallel imaging. The more we undersample, the more noise we see. You can see this noise up grain on the image. See this graininess? We all recognize that as noise, right? Nobody has any trouble with that. Anybody have any trouble that this is noise and the grainier this image goes, the noisier it gets? We all understand that instinctively, right? Grain is noise. We know that. So this iterative reconstruction process, does a significant denoising of this data, so that we end up getting much better image quality, and we're resilient to this noise loss, noise development. Parallel 2, parallel 2.5, parallel 3. You notice that we're able to maintain that low graininess, that excellent quality across the board because of that powerful denoising. This allows you to do at 1.5T an exam that used to take 16 minutes. Now it takes only about 8 minutes. That's a very substantial difference in patient experience. Patients notice that. We have data in my tool chest that I acquired while I was at Magnet that showed that 3T scanners got better ratings than 1.5T scanner. Why was that? 20-30% shorter. They noticed that. So 100% shorter, that's a big deal. Now, this technology, the IP Rapid, is integrated into the open system, and these are images we obtained with the open system in very respectable scan times using this iterative reconstruction, noise reduction based on AI. You can see here the kind of scan times we used to get with the system without it, and the ones we do get now with the system augmented by this image reconstruction fueled by AI. We've gone from 11.5 minutes to 9.5 minutes, 14 minutes to 12 minutes, 16 minutes to 12 minutes, a very respectable boost in scan time, all while maintaining really excellent image quality on an open 1.2 Tesla magnet. Again, open 1.2 Tesla magnet, I don't think anybody would have any trouble imagining this as a 1.5, perhaps even a 3T. It's got excellent spatial resolution. It's got excellent signal to noise, excellent homogeneity. Again, the same knee exam, a 1.2T scanner, reasonably short scan times as you've seen. Here are the actual scan times, typical, what does it say, shoulder in 11.5 minutes, knee in 10 minutes, ankle in 10 minutes. And this again is really a 1.2 Tesla magnet using essentially the first stage of MR-based, AI-based image reconstruction. You can see from this top row compared to the bottom row, substantially shorter scan times, about a third shorter, 40% shorter, about a minute shorter here, 3 minutes to 1 minute, about a third shorter. And again, just shorter across the board. The faster version, the standard version, and the excellent matching of image quality. Again, on the top, you can probably see the scan times here, standard, and then on the older system, and then what the newer system does with the new form of reconstruction in very respectable scan times on an open system, getting really, really sharp images. All right. Where we are today, though, is with the addition of deep learning, convolutional neural networks augmenting the noise reduction and image quality in these cases. This is currently available on the 1.5T system and will be available in the future on the newer platform. And all this does is it adds on convolutional neural network based denoising on top of the iterative reconstruction process. And you end up with both two different types of denoising, preserving sharpness, and even doing things like removing truncation that we'll talk about beforehand. Now, I don't know that there are radiologists in the room. Are there radiologists in the room? Anybody? Or are we all working on the technical side? There's one over there, okay, but she's a ringer. We substituted her. She doesn't really count for this question. Of course, she counts for everything else. But has anybody dealt with radiologists and some of these new AI-based or deep learning-based image reconstructions, and you get this kind of a quote? You know, the image looks too smooth. I just don't trust it. I think I might be losing something. Have you heard that before? Okay, radiology orients, you say this stuff, right? You look at this image, it has some substance to it. And this one just looks so shiny and nice. Is that fair? And you wonder what you're losing. Well, the interesting thing about this is the same acquisition, no deep learning. You do it 1x, you do it 4x. And what you're really seeing here is the absence of noise. Not the presence of smoothing, not the presence of reconstruction. It's just the absence of noise. Radiologists think that graininess is quality, and you have to train that out of them. If you take the same case and compare the actual deep learning of this image, at 1x versus 4, you say, wow, changes your whole perception, right? This grain is noise, okay? Grain is not quality. Okay, grain is noise. Makes great bread, but it's not good for your images. So you can see the way this works. Standard deep learning. Nice image quality is patient with metastatic disease. Again, gradient echo, standard way, same image processed with deep learning. Again, even diffusion, which again is not ubiquitously available from all the vendors you'll see here at the meeting. It's nice to be able to get a nicer looking image with less artifact. This actually gets less artifact because it's multi-shot diffusion as opposed to single shot, but nevertheless, really excellent signal quality. And again, as I mentioned beforehand, the ability to apply deep learning reconstruction to a radar or a modified radial trajectory case space is not a ubiquitous thing, but particularly important when we're doing these Alzheimer's patients. So again, here's another example. Lots of grain here, okay? That's the 1x exam. We take that exam to 4x, and we end up with less noise. But you know what? The longer scans have more motion, and you see the problem, right? You see the problem, we got motion. Even though theoretically, MR physics would dictate that more repetitions, you have less motion through averaging. It turns out that in clinical practice, where we scan and the times we scan, the longer the scans go, the more motion we have, the shorter the scans go, the less motion we have, particularly at high field. And so if essentially we take this image, this scan time, we get no motion, and we clean up all of this noise, all of this grain with deep learning, and this is a 1x acquisition. So pretty impressive stuff. So if you look at these, 1x acquisition, a little noisy. Go to 3x, it becomes a clinical gold standard image. Take the 1x image, process it with clear, and it becomes a maybe even better image. So again, 1x, 3x, 1x process with deep learning. You guys can see that, right? In this light, see it pretty well? Yeah, I think that's pretty impressive stuff. So again, an accelerated scan, same scan, processed with clear. Again, the accelerated scan, same scan, processed with clear. What do you see? Absence of graininess, preservation of sharpness, maybe some circumstances where when the noise is high, you end up with better contrast resolution, things you couldn't see, extent you couldn't appreciate. Again, three of the same patient's ankles. This is the 1x scan. This is the 4x scan, so 4 times longer. Okay, you can see there's a little graininess here. It's not the best example for a bad scan, but if you look, particularly when you get to the edges of the core, lots of noise, right? Okay, that noise disappears when you substantially increase the signal, but you can actually make it disappear with technology and respect the patient experience to the order of 1/4 of the scan time. So with any tool like deep learning reconstruction, you can take different approaches, right? The start comes with how hard can you accelerate How short can your scan be? And let technology, let AI help you clean up that image and maybe even give you a better image. So you have two ways to go with this, right? You can go with your standard spatial resolution, your standard slice thickness, and take all of that benefit in scan time. Or you can elevate your expectations and take some of that speed, some of that signal, and divide it into smaller and smaller boxes and get higher spatial resolution. But in all cases, you can see the scan times, the time savings is formidable, much more impressive than we saw with just the iterative reconstruction alone. So again, standard image processed two ways: conventional reconstruction, deep learning reconstruction. What do you see? Better contrast resolution. Actually, maybe not. Sorry, I think that, yeah, I must have mismatched the slide. Better contrast resolution. Again, same thing. Better better sharpness, maybe better contrast resolution, certainly less noise. You see all the salt and pepper out here? See all this graininess? It's noise. It's nice to get rid of that. Here's a prostate. Respectable image. Notice how even your contrast resolution in the peripheral zone of the prostate goes up because the noise levels have gone down so much. It's pretty impressive. Same data both ways. Sharpness increased, signal to noise increased. Same thing here. Ovarian lesion, sharpness increased, signal to noise increased. Bladder lesion, just a better image. And that's the thing everybody's seeing today. If you're doing this on your scanners, you know the higher patient satisfaction. For radiologists, we're under a lot of stress. We're reading more cases than we ever have beforehand. Okay, it makes us cranky and it makes our job tough and it leads us more towards, maybe I should just retire. Okay, and that's a big crisis for the industry. I notice when I read a scan that is noisy, that has an artifact on it, my stress levels go up. And they don't go down until I close that case. And that entire case is kind of like flying on a noisy airplane. It's stressful. I look at a data set that is sharp, that is high signal to noise, that is low artifact because it's fast, that is has great contrast resolution. I just feel the stress melt out of me. I actually feel it. I've said that in front of radiology audiences innumerable times, thousands of people listening. And it's the one that people come up to me and say, of all the things you said today, that resonates with me the most. I really do feel a lower level of stress when my images are gorgeous, and that really is important. Just another example, clearly sharper, clearly better SNR, and again, without losing any of the integrity of the image. This breast image is another nice example of how this can be done on 3D acquisitions as well. Now, last piece is really more of a MR, sophisticated piece, but it's one of the things that leads to poor image quality that is very poorly understood in the clinical radiologist population, and that is this truncation effect. You can see fairly striking rigging here in this brain image, but on the spine, it's a little more sinister. This spinal cord looks really small. We have Gibbs-related artifact projecting increased signal in the substance of the cord. The radiologists, we don't know why these images are terrible, but they're terrible. Okay, this is truncation effects, right? One of the nice things about Clear is it actually directly attacks those truncation effects, like some others do in the industry as well. Again, not ubiquitous. Maybe 2 or 3 of the companies, but certainly not all of them are attacking truncation. Really a reflection that this is, again, we're talking about a company and a platform that is truly at the cutting edge of things that we care about in day-to-day practice. It also deals with these truncation effects. So here, same exam. We turned the truncation filter off here, so we made it really bad, right? So this is the same exam processed by DLR Clear. The same data. Not the same patient, the same data. This is how bad truncation can affect an image in clinical practice under certain circumstances. If you take this one, which doesn't look that bad, and this one, you can take a look at the spinal cord. If I have my glasses on, you can see it almost looks like a mozzarella steak. You can sort of peel layers off the spinal cord. That's not real, that's truncation. We can get rid of that with deep learning, but you see if you subtract it to, this is what's in there. This is the garbage that's in there. That's truncation. The only thing that's different between the two, truncation. And again, this is with a truncation filter on. This is not so bad. But if you look carefully at the size of the spinal cord here, it's not a perfect reduction of that truncation. The other thing you notice is that even though the scan spatial resolution is the same, the image on the left is softer. Because when you use a truncation filter, you discard the periphery of K-space, some of it, and that throws away some of the spatial resolution that you're paying for with scan time. So you can see the resolution loss here in another case. This is a conventional scan with a truncation filter. This is clear without a truncation filter, but with the capability of reducing truncation in the actual acquisition. And subtracted to, you see the spatial resolution you've thrown out. It's not free. So it can be pretty formidable, being able to correct some of these really annoying artifacts. Now, this is a really bad example, but if you look, at brain images, you just see these things that just interfere with the excellence of the image. These little parallel ringing lines at the edge of the image. Okay, you can see this particular set at this magnification, maybe you can't see, but we always see truncation next to the falx. Okay, you can see these multiple parallel lines in the right frontal cortex. If we use a truncation filter, we soften those, but they're not completely gone. If you use a DLR clear, we actually maintain the spatial resolution of the original, rather than the trade-off in spatial resolution here, and we do an even better job with that truncation. I was in the factory scanning just last week, and we did this example. You see the same effect here. Hard for me to see without my glasses. I want to put them on because I like to see what I believe what I see. And I know that it's there because I put the slides together with my glasses on. But you can see the truncation effects right here. We've softened them, almost eliminated them here. But you see we've given up a little bit of spatial resolution. But if we use deep learning for this, we use the DLR clear for this, you can see we get the resolution we have here with an even better reduction of the truncation. Now this is reflected in neuroimaging and spine imaging, probably the most important area, but you'll see it in the knee, you'll see it in other areas. You'll see it any time there is the right orientation of structure and significant differences in the tissue nature. But even on this pelvic exam, you'll see there are classic areas where truncation shows up. And what does this feel like to a radiologist? It feels like a bad image. It feels like an old image. It feels like a not great image. That's what I feel when I see this. If you can eliminate that and even improve the SNR, maintain or increase the sharpness of the image, you end up with a overall better experience for patients. So, as Shawn mentioned earlier, we really appreciate you hanging in late for this, but we really did. I hope I was able to, and I know Shawn was able to, give you a sense of how technology is changing our relationship with the patient, allowing the scanners and the institutions that do the scanning to be more patient-centered, It is an altruistic endeavor, but it is also a highly commercially sensitive endeavor where, again, happy patients are more efficiently scanned, they are more sensitively handled, and they will come back and visit you once again. We talked again about how it affects the image acquisition. Some of the remarkable things we see in IQ retouch. I've been an MR as a clinician and a technical director in practice for over 35 years. These are some of the more impressive things that I've seen in my years of practice. I would say that deep learning reconstruction is probably the most impressive generational change in all the years I've been working in MR. And you can see how these tools working together do increase our ability to get things right the first time. Again, the ultimate patient-centric, the ultimate economically sensitive thing that we can do in day-to-day practice. So I hope that was fun. Didn't take too long. And we'd be happy to take any questions, engage in any kind of discussion that you might feel the urge to have. Thank you for your attention. Any questions from anyone? Here's one. Oh, nice.
Thank you very much. Actually, one question, maybe use, for example,
Sure, let's come up. I'll turn on your mic.
All right.
the clear technique to reconstruct the image. Do we still have access to the original one that if we have not used that technique? So
No, I think to restate your question, do you have the untreated image? I'll let Shawn answer that.
Yes, you do. So the raw data is preserved for a certain amount of time, and I think in the next software version, we're extending that amount of time so that you can manage the data in a different way if you want to.
By the way, that's where the demos come from, right? The ability to show you what it looked like had I not processed it. So we went back and retrospectively corrected the bad version.
So because sometimes some abnormalities look like some, artifacts, and then person who wanted to judge it quality need to look at both of them.
Yeah, I mean, it's a concern, right? But, I've been doing this myself in very, very busy clinical practices, probably for 6 years. I know of not a single incident where we felt that something was hallucinated. We are not stretching here with deep learning reconstruction. We're all familiar with the stretches. I remember being at the ISMRM, they were showing parallel imaging factors of like 30 scans that took less time than actually not doing the scan. Okay, and they said, don't do this at home. This is not a don't do this at home type circumstance. This is a do it with great alacrity. We're not stretching things, and I think the reliability is extremely high. I haven't seen a single circumstance. I would say, however, as an experienced user, that if there are artifacts present in general, and this doesn't apply to a Fuji image, which was, as you saw, never has an artifact. But if an artifact is present, it will be more prominent if you reduce the noise, because noise is incoherent, right? But signal is coherent. So you get rid of all the random stuff and all the signal is there, good or bad. And there have been some circumstances with different vendors where perhaps there was aliasing along the face encoding direction, and it may have produced an artifact somewhere that you would have ignored before, but then all of a sudden cleaning up all the noise, oh my God, look at that. Remember 3T? When we first got 3T, it was like, all these artifacts look so much worse. Well, because the noise has been markedly, the noise floor is much, much lower. That's really the only thing that's negative. I had one of my buddies say, we used to reading noisy images. Maybe it'll be harder to read these images without noise because maybe we'll do it wrong. We have to prove that we can read this with no, I don't think so. I think we know, my old mentor used to say to me, good is good. Look at these images, you see that they're good, and it doesn't take very long to build trust. Anybody else want to come up with a really challenging question? That was a good one. No? Let me ask a question myself. Okay. You're all working at institutions across the globe. Is anybody working at an institution using deep learning reconstruction? It's just not even physically possible. Susie and I are the only people doing this. I guess we have a Shawn group here. Is there anybody working at an institution where the institution itself says, I will not do this. I don't believe in deep learning reconstruction. This is evil. It could cause hallucinations or anything else. Anybody want to say that? Okay, just wanted to make sure anybody's listening. Does anybody wish there was better food on the buffet? Okay, there you go. I'm going to make sure there's at least one of them. Thank you very much for your attention.
Very good. Again, like I said at the outset, I'm humbled and very gratified. You're so gracious with your attention at the end of a very long day, and I appreciate it so much. Come by the booth, seriously, and talk to us about a little bit deeper about any of these things. We've got folks in the booth that know it clinically and know the technical aspects of our products. So come by. Take care. Have a great evening.